Welcome to this Step 3 review on osteoporosis and metabolic bone disease from roadmap to residency. We won't reteach the topic. Instead, we'll show how the test writers build these stems and give you a repeatable way to attack them. Bone density interpretation, when to reach for a bisphosphonate and when not to, how calcium and vitamin D fit in, and the Falls vignette. We'll work 3 practice questions and explain every choice. Keep your question bank open. Let's get started. Here's the plan. First, hunt for the one number that drives every bone density question, and ignore the distractors planted around it. Second, never prescribe on empty ground. Correct calcium and vitamin D and look for a secondary cause before starting a drug. Third, attack the Falls vignette, where the answer almost never involves a new prescription. In your question bank, find osteoporosis under endocrine bone disease and fall prevention under geriatrics and preventive medicine. Strategy 1. Hunt the bone density number. Every vignette buries one decisive value, so find it before reading the choices. A T-score at or below -2.5 is osteoporosis, and osteoporosis means treat. Between -1 and -2.5 is low bone mass, usually lifestyle measures and a fracture risk calculator. Better than -1 is normal, but fracture overrides everything. A hip or spine fracture after minor trauma is osteoporosis regardless of the scan. If the stem gives a fragility fracture, the diagnosis is made, and ordering another scan first is the trap. And in men under 50 and younger patients, use the Z-score, not the T-score. Strategy 2. Never give a drug on empty ground. Before any bone medication, the exam wants calcium and vitamin D replete. Low vitamin D plus a bisphosphonate risks low calcium, and the test punishes that order. So if the stem quietly reports low vitamin D or low calcium, replace it first rather than prescribe. When one choice starts therapy and another replaces vitamin D, replacing usually wins. Then look for the secondary cause hiding in the lab panel. High calcium with a high or inappropriately normal parathyroid hormone points to overactive parathyroid glands. Low vitamin D with a high parathyroid hormone points to soft bones from deficiency. An isolated high alkaline phosphatase in an older adult with bone pain or hearing loss points to abnormal remodeling. Strategy 3 covers falls, treatment duration, and the overkill trap. In a falls vignette, the answer is almost never a new medication. Scan for the sedating drug, the blood pressure that drops on standing, poor vision, and the loose rug. Stopping the offending drug, reviewing the medication list, and referring for supervised exercise and gait training beat everything else. Home safety evaluation is a favorite correct answer. Second, bisphosphonates aren't forever. After about 5 years of oral therapy, a lower-risk patient with no fracture and improved density can take a drug holiday, while a high-risk patient, or one who fractured on therapy, continues. Third, beware the impressive answer, a full workup on a straightforward postmenopausal patient, an injectable anabolic first line, or advanced imaging for a classic vignette all do more than needed. First practice question. A 67-year-old woman comes in for a routine visit. She's never fractured, doesn't smoke, and walks daily. Her mother broke a hip in her 70s. A screening bone density scan shows a lowest T-score of -2.7 at the femoral neck. Calcium, kidney function, and vitamin D are all normal. Before the choices, find the number and ask what it commits you to. Then ask whether anything in the panel needs correcting first. Pick your answer. Let's break it down. Spot the number. A T-score of -2.7 is at or below -2.5, so that's osteoporosis by density criteria, and the normal calcium, kidney function, and vitamin D aren't filler. They tell you the ground is prepared and nothing needs correcting. Apply the rule. Confirmed osteoporosis in a postmenopausal woman with normal labs gets first-line therapy and oral bisphosphonate with calcium and vitamin D, which supplement the drug but never replace it. Now eliminate. Repeating the scan delays treatment in a patient who already qualifies. Exercise alone is the undertreatment trap. Parathyroid hormone plus a bone scan is overkill when the panel is normal. The answer is weekly oral alendronate with calcium and vitamin D. Second practice question, testing sequencing. A 72-year-old woman is seen 2 weeks after she fell from standing height and fractured her wrist. She's never had a bone density scan and feels well. Calcium and kidney function are normal, vitamin D is low at 14, and she takes no medications. 2 clues are planted here, not 1, and the right answer respects both. Find them, choose your answer. 2 clues. First, the fracture. A wrist fracture from a standing height fall in a woman in her 70s is a fragility fracture, which means osteoporosis regardless of any scan. Second, vitamin D of 14 is deficient. Both were planted on purpose. So sequencing wins, replace vitamin D, then begin bisphosphonate therapy. Starting alendronate today ignores the deficiency and risks driving her calcium down, exactly the mistake this question is built to catch. Ordering a scan first is the delay trap, since the fragility fracture already made the diagnosis. And reassurance is wrong, because a fracture from standing height is never expected at any age. Metabolic bone questions are solved in the labs, not the paragraph. Go straight to calcium, phosphate, alkaline phosphatase, parathyroid hormone, and vitamin D, and name the pattern before reading a choice. High calcium with high parathyroid hormone is overactive parathyroid glands. Low vitamin D with high parathyroid hormone is soft bones from deficiency. Isolated high alkaline phosphatase in an older adult is abnormal remodeling. Naming the pattern collapses 4 choices into one. And set a ceiling. Give yourself about 90 seconds, and if the pattern hasn't surfaced, commit, flag it, and move on. One dense panel isn't worth 3 other questions. Third practice question, the fool's vignette. An 80-year-old woman comes in after 2 falls in 6 months. She lives alone. Her medications include a nightly sedative for sleep and a blood pressure medication. Her blood pressure drops when she stands. Her vision was last checked 6 years ago, and her gait is slow and unsteady. Her bone density scan last year showed a T-score of -2.2. Notice how many details are things you could actually change, and ask whether that T-score meets criteria for anything. Choose your answer. Count the planted risks. A nightly sedative, blood pressure that falls on standing, vision unchecked for 6 years, and an unsteady gait, all modifiable. And her T-score of -2.2 is low bone mass, not osteoporosis, so bone density isn't what this tests. When a vignette stacks modifiable risks, the answer removes them. So reviewing and reducing her medications and referring for gait and balance training is correct, addressing the sedative, the low standing blood pressure, and the unsteady gait at once. Brain imaging is overkill with no focal findings. An intravenous bisphosphonate is wrong twice, since her density doesn't meet criteria and it prevents no falls. And a nursing facility strips her independence before reversible causes are touched. Here's the pearl that ties it together, a 3-question filter for every bone vignette. 1. Does this patient already have osteoporosis by a T-score at or below -2.5 or a fragility fracture? 2. Is anything correctable first? A low vitamin D, low calcium, or an untreated secondary cause? 3. Is this actually a falls question in a bone costume? Those 3 resolve the vast majority of what you'll see. Then choose the smallest sufficient action. If the ground is prepared and the diagnosis made, treat. If a deficiency sits in the panel, correct it first. If the patient keeps falling, remove the risk before adding a drug. Only change a confident answer when you find concrete evidence you misread the stem. That wraps up osteoporosis and metabolic bone disease. Remember the core ideas. Hunt the bone density number, and remember, a fragility fracture makes the diagnosis by itself. Never give a drug on empty ground, so correct vitamin D and calcium first, and look for the secondary cause in the panel. And in a falls vignette, remove modifiable risk before adding a prescription. Drill these patterns in your question bank under timed conditions, under endocrine for osteoporosis and geriatrics and preventive medicine for falls, and read every explanation, even when you got it right. Visit roadmap to residency.com for tutors and advisors who can build you a personalized study plan. If this helped, please like and subscribe. Good luck on your exam.